So there's this pattern playing out in doctors' offices across the country right now. Women in their 40s sitting across from a clinician describing what sounds for all the world like ADHD. Trouble focusing, can't hold a thought, impulsive, overwhelmed. And a lot of them are getting an ADHD diagnosis for the first time. The thing is, estrogen has been quietly running part of their dopamine system for decades. And as it drops, that system starts misfiring. Whether that's a new condition or an unmasked one is a question worth sitting with. And we're going to get into it today.
Hi there, I'm Tony Lee, and this is Hot Flasher, your daily menopause podcast that serves up fresh news, research, and wellness tips. I've built a daily news pipeline to find the latest on women's health and menopause research. Allow me to introduce my co-host, Nikki, who handles the headlines. Take it away, Nikki.
Thanks, Tony. We've got a good one today. 3 symptom stories, all of them underreported. One of them genuinely reshaping how some clinicians think about a decades-old diagnosis. Let's start with the ADHD thing, because it deserves the most space. Over the past several years, there's been a noticeable uptick in women being diagnosed with ADHD in their 40s and 50s. And the question that researchers and clinicians are now taking seriously is, what's the relationship between that timing and menopause? Here's the biology. Estrogen isn't just a reproductive hormone. It does a lot of things in the brain. And one of the most important is that it modulates dopamine, the neurotransmitter that's central to attention, executive function, working memory, impulse control. All the things that ADHD affects. Estrogen helps regulate dopamine receptor sensitivity and affects how dopamine is synthesized and broken down. So when estrogen levels start declining in perimenopause, some women experience what looks from the outside exactly like ADHD. There are really 2 groups here, and it's worth distinguishing them. The first group is women who never had ADHD, or at least never had significant enough symptoms to notice, and who are now experiencing attention difficulties that are directly tied to the estrogen drop. Their dopamine regulation was probably fine before, and now it's not. For them, this may be a menopause symptom that responds to hormonal treatment, not a psychiatric diagnosis. The second group is more complicated, and honestly, more fascinating. These are women who likely had ADHD all along, but estrogen was doing enough work in the dopamine system to partially compensate. They struggled, maybe, but they functioned through school, through careers, through raising kids. And then perimenopause hits and the compensation disappears. Suddenly, they can't do the things they've always done, and nobody can figure out why. These women often end up in a psychiatrist's office getting a first ever ADHD diagnosis in their late 40s, and the diagnosis isn't wrong. It was just masked for 20 or 30 years. My read on this, the medical system is not set up to catch either group well. A 5-minute GP appointment is not going to surface the hormonal context. A psychiatrist doing an ADHD evaluation may not ask about menopause status at all. And a gynecologist managing menopause symptoms may not think to screen for ADHD. So women fall through the gap between specialties, which is a pattern we talk about on this show a lot because it keeps happening. The Garrison piece in the Star Tribune doesn't go deeply into the research methodology. It's more of a general awareness article. But the underlying biology is solid and increasingly well documented. Estrogen's role in dopamine regulation is not contested. What's still being worked out is the clinical pathway. Who should be evaluating these women, in what order, and with what treatment approach? Because stimulant medication and HRT may both be relevant, and the interaction between them hasn't been studied nearly enough. If you've been struggling with attention, impulsivity, or executive function, and you're in perimenopause, that's worth naming specifically with whoever you're seeing. Not as self-diagnosis, but as relevant context. Dr. Makeba Williams, who appeared on Dr. Streicher's Inside Information podcast, uses a term I want to borrow: esoteric symptoms. And she's careful to define what she means by it. These aren't rare symptoms. Rare would be unusual. Esoteric means they occur commonly but are almost never discussed, and so women don't recognise them as menopause, and clinicians often don't either. Some of these you may know: brain fog, joint pain, hair thinning. But Williams goes further, into territory that I think a lot of women will find either validating or startling, depending on where they are in the journey. Electric shock sensations, the feeling of a quick zap under the skin, sometimes before a hot flash, sometimes on their own. Formication, which is the sensation of insects crawling on the skin. Burning mouth syndrome, where the tongue or the roof of the mouth feels like it's been scalded, often with no visible cause. Tinnitus, ringing or buzzing in the ears, which has been linked to estrogen receptor activity in the inner ear. Dry, itchy skin that doesn't respond to moisturiser the way it used to, because the texture of skin is also estrogen dependent. None of these are exotic. Women report them constantly on places like menopause and perimenopause. They're in the top recurring posts. And yet a woman who goes to her doctor describing a burning sensation in her mouth or electric shocks under her skin is probably not going to hear that's perimenopause as the first response. She's more likely to get a referral to a neurologist or a dermatologist or a dentist, burn through months of appointments, maybe get nothing, and eventually either find the answer herself or just stop asking. The clinical literacy gap here is real, and I don't say that to shame individual providers. The average physician genuinely does not get comprehensive menopause training, but the consequence is that women are gaslit or, at minimum, deeply confused about a set of symptoms that are affecting their daily lives. Naming them is useful. Knowing the list means you can bring it to your provider, frame it in terms of hormonal context, and push for a more informed conversation. The study I want to close on is from the NAMS journal, Menopause, and it's about diet, specifically a soy-supplemented vegan diet and its effects on hot flash severity. Some context first. This is a secondary analysis of a randomized clinical trial. That distinction matters. The original trial wasn't designed to test whether plant foods reduce hot flashes. The primary endpoints were something else. This analysis looked at the data afterward to see if there was a pattern around food group substitution. Secondary analyses can be genuinely informative, but they're hypothesis generating, not hypothesis confirming. So I want to be accurate about what this paper is and isn't. What they found in postmenopausal women following a soy-supplemented vegan diet, replacing animal foods with plant foods, regardless of whether those plant foods were minimally processed or ultra-processed, was associated with significant weight loss and a reduction in severe hot flashes. The processed versus unprocessed distinction didn't appear to be driving the effect. It was the animal to plant substitution itself. That's interesting for a couple of reasons. It complicates the ultra-processed food narrative a little, at least within this specific context. The assumption is usually that processed plant foods are bad and whole plant foods are good. Within this study's parameters, that didn't hold up. The relevant variable was the food category, not the processing level. The soy component is worth noting. Soy contains phytoestrogens, specifically isoflavones, which have a weak estrogenic effect and have been studied in the context of hot flashes for a long time. The evidence on soy and hot flashes overall is mixed. Some studies show benefit, some show minimal effect, and outcomes seem to vary by individual metabolism. This study layered soy on top of a broader dietary shift, so it's genuinely hard to separate what was doing what. What I'd push back on is any headline that reads this as "Go vegan and fix your hot flashes." That's not what a secondary analysis of one trial tells you. What it does suggest is that the dietary context for hot flash severity is worth taking seriously, and that a whole diet approach, not just adding a supplement or cutting one thing, may be where the signal actually lives. That's a more useful framing than the individual ingredient rabbit hole most wellness content sends women down. The weight loss finding is also relevant because excess adipose tissue is itself associated with more frequent and severe hot flashes. Fat tissue produces estrone, a weaker estrogen, but the inflammatory environment it creates can also amplify vasomotor symptoms. So some of what looks like a dietary effect on hot flashes may be mediated by weight change. The study can't fully untangle those two things, and it's worth knowing that. If you're already eating a mostly plant-based diet or considering it for other reasons, this is one more reason the research seems to be pointing in that direction for menopause specifically. If you're not, a secondary analysis from one trial is not the evidence base to make a major dietary overhaul on. Talk to someone who can actually look at your full picture.
Thanks for listening to Hot Flasher. We're back tomorrow with more, so don't forget to subscribe. See you tomorrow.